My pleasure to introduce a friend and colleague, Peter Can. Peter and I trained together in residency in Utah, and then he became a fellow of the Royal College of Physicians and Surgeons in Canada prior to doing his endovascular fellowship in Buffalo, where we met up again. And we were talking last night. We've been friends for 20 years, so now you're more like a brother than a colleague. But besides just being a really good friend, he's also a very impressive guy. Peter is professor in the Robert L. Moody Senior Chair of the Department of Neurosurgery and Jenny Seeley Distinguished Chair in Neuroscience at the University of Texas Medical Branch in Galveston. His research interests include clinical trials for neuroendovascular devices. He has multiple grants, hundreds and hundreds of publications, and he's also really looking at neuroprotection for acute ischemic stroke and intraarterial cell-based therapy for malignant brain tumors. So today he's going to be talking to us about treatment of carotid cavernous fistulas and sort of endovascular and open surgical hybrid approaches. So, Peter, thank you.
Well, good morning, everyone. Want to really honored and an absolute delight to be here. See everyone in person. You know, we've been doing Zoom for so long, right? You had to ask, can you hear me? Can you see me? So I know here you guys can hear, can see. So first, I want to really thank Mandy and Errol. I've known Mandy now for 20 years. We're residents together, fellows together, you know, and also Dr. Vess, Errol. I've been a mentor and a friend for over 10 years. I mean, that went by pretty fast, you know, and just really, I mean, it's no bigger honor than to be invited by good friends and mentors. So thank you. So I thought we'll talk, you know, I know it's a broad audience, you know, neurology, neurosurgeons, mid-levels. And so I think we'll pick a clinical topic, you know, I mean, CC fistula is a good one. I mean, I've kind of stumbled upon a few interesting cases over the last 10 years. And I think it's something that neurologists see, surgeons see as good a hybrid endovascular open topic. So hope you enjoy for the next hours. So these are some of the disclosures, none of which is relevant to the talk today. So this is the outline of the talk. So I'll quickly go through CC fistula, talk about the anatomy of the cavernous sinus, which is really critical to the understanding of the treatment. I like history, so we'll talk a little about the history. There's an interesting history behind this, really tied to how endovascular therapy was developed. Talk a little about currently what we do, a little bit of novel things, and kind of a few interesting cases that I've come across and have to solve pretty recently. So most of you know the classic triad of this disease is you get the exophthalmos, you get the chemosis, and you get visual problems. For this entity, if left untreated, you can get ophthalmoplegia, you can get visual loss. And yes, you can die from carotid cavernous fistulas. We often say it's kind of like more of a benign spectrum of vascular disease, but you can get subarachnoid hemorrhages, you can get fatal nosebleeds, and you can get strokes. And all this happens because of the cavernous sinus is arterialized. Basically, the shunting from the carotid arteries to the cavernous sinus. Cavernous sinus become pressurized, and all the bad things arise from there, whether it be intracerebral hemorrhage, you know, kind of intraocular pathology and symptoms. So this is the Barrow classification from Dan Barrow. So it's a nice way to think about this. So the fundamental problem is that there's a connection between the carotid artery and the cavernous sinus. So it could be like a hole in the carotid, like a type A, you can see a type A fistula, or it could be just indirect small connections from not from the carotid itself, but from the branches of the carotid, the meningeal branches. Could be the ICA, like in type B, from ECA and type C, and commonly both the ICA and the ECA in type D. So the type A is what we call a direct fistula, a hole in the carotid, direct connection. The BCD are indirect fistulas from the smaller blood vessels, low and slow flow. The type A are high flow, as you suspect. So why are there holes in the carotid in the first place? So the most common, I'm sure all the neurosurgeons here see this, is from trauma. Probably the most common scenario for the high flow fistula is trauma. A young person, high speed MVA. It could be from aneurysms. You know, even though we know cavernous aneurysms are usually pretty benign, but they can rupture and can give you fistulas. And as endovascular people, you know, this is the dreaded call we get, but we probably get it once a year, you know, from a busy pituitary practice, you have carotid injury. So these are probably the three common reasons why we see a direct type A fistulas. And in terms of workup, 6-vessel angiogram, I know it's like a slide, I've changed the colors. The colors are bad, but the angiogram in this case is absolutely critical to get a 6-vessel angiogram. And you look for different things. For these direct fistulas with a hole in the carotid, you really want to see the collaterals of the circulation because you may want to sacrifice that carotid. For the indirect fistulas, you want to look at the externals to see if the externals supply it. But the common thing that you must look at, which we'll talk about more, is the anatomy. You need to look at the anatomy of the cavernous sinus because that's the way to treat this. So I think like many things in neurosurgery, the concept of the treatment is pretty straightforward. You got to go to the cavernous sinus and plug up the hole or to plug up the point where the connection occurs. But the carry out of this is not so easy sometimes. So these are some of the routes, some of the natural pathways that drains the cavernous sinus or drains into the cavernous sinus, and kind of potentially routes that we can get to it. So moving on to anatomy. So unlike in the anatomy textbook, the cavernous sinus is a tributary of veins. I mean, so most of the time it's like a network. It's not really like one compartment. So it makes it kind of challenging because sometimes the fistula only happens at one compartment. So to get to that one compartment sometimes is difficult. So of course on the either side of the sphenoid bone. So there's the intercavernous sinus that connects the two sides. There's anterior and posterior part. Now going into some of the craniofacial veins, which is important. So the pterygoid plexus is one of the outflows of the cavernous sinus, and this is why people can have nosebleeds from this. So if the cavernous sinus is pressurized, then the pterygoid plexus can be pressurized and you can get epistaxis from it. Very uncommon. I don't think I've actually personally seen a case. Now going to these other veins, these are important routes to get access to the cavernous sinus. So as you know, the superior ophthalmic vein usually drains the orbit and goes into the cavernous sinus. So this one route, we can think about getting to the cavernous sinus to the fistula. And then there's also the inferior ophthalmic vein, smaller, but also a possible route. I'll show some cases. The angular vein, is a very tortuous vein, but it connects the anterior facial vein to the superior ophthalmic vein. So that's another route. So all these are routes to get to the cavernous sinus for the treatment. So the anatomy here is really practical. And just for completion's sake, the posterior facial, the retromandibular vein here, and the deep facial vein that connects the pterygoid plexus to the anterior facial vein. Other pretty familiar spaces to the neurosurgeons and neurologists, the superior petrosal sinus, another route that drains the cavernous sinus. We can get to it, from that. And the workhorse, probably the inferior petrosal sinus from the jugular vein in terms of access. So lastly, for those of us who do craniotomies, when you do sylvian fissure dissection, good catch. So you do sylvian fissure dissection, you see the middle cerebral veins drains to the sphenoparietal sinus that drains to the cavernous sinus. So that's an interesting route, and I'll show some examples of that too in terms of how to access the cavernous sinus. So a little bit of history. So in the past, before people did autopsies of the brain and craniotomies, it was thought to be a disease in the eye and in the orbit because the manifestation is usually in the eye. So Benjamin Tarver was a British surgeon who was credited to have tried some of the first treatments. Back then, there's nothing else they can do except to compress on the carotid and neck. He even tied off the carotid without anesthesia. So that's way back in the early 1800s. And subsequently, with autopsies and whatnot, people recognize that it's actually a problem north of the orbit. It's an intracranial problem, and they start to have that understanding. But still, there's really no treatment, even up to the 1900s, apart from you see here putting clamps and putting pressure on the carotid. You just realize that some of the fistulas, the symptoms get better when you compress the carotids. So after Tarver, the next kind of champion to this is, like anything else, is Walter Dandy. So he was the guy at Hopkins who clipped the first aneurysm, and then he kind of realized that, well, you can trap these things, So apart from just tying off in the neck, which is the proximal occlusion of it, you can also go to the distal part beyond where the injury part for the direct fistula is, and then you can trap the fistula and cure it that way. So he used to describe putting clips on kind of proximal to the PCOM and trapping these aneurysms. Of course, for patients without Circo-Willis, they have big strokes. So still, a pretty morbid procedure at that. But he was really the first one who was able to cure some of these direct fistulas for patients. So after Tarver, Walter Dandy, and then it came to Dwight Parkinson. I don't know if any Canadians in the audience, a famous Canadian neurosurgeon who pioneered a lot of the approaches to the cavernous sinus. So really, with Dwight Parkinson's work, it became possible to have a artery preservation and nerve preservation option. So, I mean, he basically opened up the cavernous sinus and packed the cavernous sinus with whatever material he can find. But that was really the first time that we can treat these things without tying off or injuring the carotid or cranial nerves. The problem is that he did a lot of these under hypothermic cardiac arrest, so a lot of blood loss, a lot of morbidity. So, so not exactly like a straightforward procedure. So, like they say, the necessity is the mother of all invention. So that kind of pushed the endovascular therapy to attack this problem. So the balloon technique we all heard with that I've never seen this, but kind of read it from textbooks and papers. So Sobernenko from Soviet Union was credited to be one of the first people to do this. Basically, float balloons, to the hole and detach balloons there to close the fistulas. Of course, it's hard to control compared to what we have now, but what they had was very primitive. Hard to control where this goes to, and often cause strokes and embolic problems. On the arterial side, as we know, it's much more dangerous to do anything on the arterial side. So De Bruyn's group, he's French, but I think his work in London, Ontario with Charlie Drake's group at the time, start adopting the balloon but on the venous side, much safer, kind of like a better success rate. He basically just float these balloons through the petrosal sinuses, the IPS. So it's kind of forming the modern way to treat these fistulas, basically a transvenous approach, a safer approach to the cavernous sinus, and packing the venous side of this. Of course, now for the endovascular people, we know that this is what we use today. We use the coils, much softer, smoother. You can put it through microcatheters. You can target the microcatheter to the pockets that you need to target to. So, today transvenous coiling is really the first line treatment for these lesions. So that's even holds true today in 2023. And I'll show some case of failure too. So I think for the fellow, it's important to know that when you pack the cavernous sinus at the fistula, you really want to also take the proximal outflow vein, because if you don't do that and you don't kill the cavernous sinus, the vein can still fill afterwards. You have worsening symptoms and you lose the access. So it's a technical thing for the fellow. So what can we do now? Back then they used balloon. Now we use coils. Sometimes the coils don't fill it all the way. So sometimes we use liquid embolic. So these are like things like crazy glue in terms of NBCA and kind of cohesive polymers in terms of onyx. So we have different kind of substance we can inject through catheters in addition to coils. So what are the results? So the results are good, so we've come a long way from Tarver tying off the carotid with no anesthesia. So now if you look at the endovascular therapy, we're talking about like a 90% success rate. So most people you send to Zach, to Ken, Arrow, and Mandy, most of the time, they have a great result. Like 9 out of 10 people get cures. So pretty good and very, very safe. Most of the time we go transvenous, so the complication rate is really, really small. Now, I must admit I've never done this, but just for completion's sake for the audience, there are non-surgical, non-endovascular options. So I guess if you really have a desperate case, you can do radiosurgery. Just like in AVM, it takes time for the obliteration to occur. There could be recurrences, could be carcinosis, malignant transformations, and all that. So I think this, in my mind, is the last resort for treating these lesions, but just for completion's sake. So for the rest of I've kind of gone through all the kind of background, a little history, a little bit of materials behind it. So the rest of the talk would just be on cases to illustrate these points. So I think this history tells it all, right? It's a young guy, high-speed MVA, so we're thinking about a direct direct hole in the carotid kind of CC fistulas. So, I know we have a wide audience. So this is what it looks like, these direct fistulas. So if you come across an angiogram, I still think it kind of always looks kind of scary, right? When you do the injection, it's like contrast billing everywhere, and you don't see any filling in the head, right? So I guess what we're looking at is that the blood is just pumping to the cavernous sinus, so you don't see a lot of perfusion to the brain, so it always looks kind of scary. So if there are any medical students in the audience, it looks scary. It looks like just contrast billing everywhere. So this is where the cavernous sinus is. Let's see, you can see the arrows on there. And then I start looking at like we talked about, like the outflow, right? This is the superior ophthalmic vein, the angular vein here, anterior facial vein, inferior ophthalmic vein, superior petrosal sinus, inferior petrosal sinus. So I start looking at routes and how you can get to that point of pathology. But it always looks kind of scary. And I'll just show one PA or AP projection. So you can see the MCA here, but it fills a little bit delay. So like we talked about, important thing to look at is the collaterals for these direct fistulas. So you always want to see what happened if you sacrifice the carotid artery. So here you see the patient is a very good circle Willis, right? The anterior communicating artery is intact. So that when you inject the left carotid, it actually fills both hemispheres equally with no delay. And this young person also, in addition, has an excellent posterior communicating artery. And in fact, you can even see where the hole is in the posterior genu of the cavernous carotid. So in this person, if you have to take the carotid, it's probably very safe to do that. Now, I think currently we have different technologies to preserve the carotid, but I just want to show a case that in this case we end up, occluding the carotid. So that's, I think, to this date is still a valid treatment for direct fistula. So in this case, patient has a hole in the carotid, has excellent collateral. So we just use coils to occlude the carotid artery. For our fellows, it's important. You can see here the coils didn't project very well. Maybe the last one is better, but you have to coil it not just at the hole. You also want to coil it before and after, because if you just coil it before, you get retrograde filling. So you have to. It's a basic principle of sacrificing a vessel. You have to sacrifice approximate distal to pathology. So in this case, with a very good curative result, you always want to do final runs on the collateral vessels too, right? You want to see the PCOM really filling the MCA, the ACOM is filling the MCA and the ACA, and then when you do the anterograde run, there's no filling of the fistula. So this patient, so that's one way, right? We can sacrifice a carotid in these high flow fistula. So this is a different patient. So the young patient, motor vehicle accident is direct fistula. The elderly female who has no history of trauma, these are usually the indirect low flow fistula. This is a 75-year-old woman, has a red eye, headache, diplopia, high intraocular pressure, has seen the ER a couple of times, and finally sent for further evaluation. So the classic findings talk about chemosis, exophthalmos, and a little bit of ophthalmoplegia and paresis. So this is the CAT scan. So again, for the trainees in the audience, you always kind of see this dilated superior ophthalmic vein that you're not supposed to see otherwise. The rest of the CAT scan is usually pretty benign. So in the MRI here, you can see there's some fullness in the cavernous sinus. So there's some kind of connection. So just cut to the chase in the angiogram on the Pernin run here. So this is the internal carotid artery run. You can see already early filling of the cavernous sinus from the meningeal branches. Probably meningeal have a pseudo trunk here. So a type B CC fistula and direct low flow fistula. So in this case, what do we do? So let me kind of just play the rest of the angiogram to again study that. So here, I'll pause right here. So again, study the outflow of the cavernous sinus. So here you have a big highway to the cavernous sinus, the superior ophthalmic vein, again the angular vein and the anterior facial vein. So in this case, I tried to go through the anterior facial vein, but just couldn't make the turn in the angular vein. So in this case, we did a direct access. We these are very multidisciplinary cases. So we work with our oculoplastics colleague here. They get access. So as you hear, there's the vessel loop that kind of isolated the superior ophthalmic vein, that huge vein that we saw in the angiogram. And we just do our standard things. We punctured it here. We kind of put our system in, and this is an interesting angiogram. Here we basically have a catheter through that cut down into the cavernous sinus. You can see here is the cavernous sinus. And then we coil the cavernous sinus, but also the origin of the superior ophthalmic vein, just to make sure that we cure the disease. And this is the final run here. You can no longer see that early shunting, from the injection. Just for completion's sake, so the first case we sacrificed a carotid. This one we went through a superior ophthalmic vein with a cut down, but the truth is that most of the time you can do it with ultrasound, with ROMAP guidance. So you don't, if you don't have access to an oculoplastic surgeon, you can do it all yourself too with ultrasound. So just to show another case of that. Now again, I like repetition. So this is the same kind of angiogram, right? A direct fistula, that scary looking angiogram. Again, seeing all the same veins is very consistent. All these pictures, to the outflow and inflow to the cavernous sinus. So in this case, a different kind of approach. In this case, I was actually able to go through the anterior facial vein. You can see anterior facial vein, angular vein, superior ophthalmic vein. So now we're kind of going to the cavernous sinus. So it's a long route. Here we went from the femoral vein in the groin, but you can also go from the wrist or from the arm up there. So this now is in the cavernous sinus, and just to show kind of what we do. In this case, we protected the carotid, so we don't want the coils to come back from the cavernous sinus to the carotid. So here we have a balloon to protect it, and this is, what we do. We just basically put a lot of coils in so that the blood cannot shunt into it. And people often ask about, well, when you put all this stuff in the cavernous sinus, does it injure the arteries or the nerves? And surprisingly, the material is soft, and it usually just displaces the nerves and the arteries, so it doesn't actually hurt it. And I think usually the risk of kind of worsening the craniopathies is pretty minimal. So this is kind of what we do, which is put more coils in. Usually we use a lot of materials in these cases, so more coils. Our reps are usually very happy with these cases. And then this is the final result. So I think, so you no longer, so it went from that scary angiogram to an angiogram. Now you see the perfusion of the brain. You don't see that shunting of blood in the cavernous sinus. So this is a better result than the last case. We were able to cure the fistula, but also save the carotid artery, which should be the goal today. So again, very familiar now. Everyone's expert in this. Again, that scary-looking angiogram. Balloon the carotid, try to protect it. I showed this case because the access is a little bit different, right? Last case went through the angular vein, anterior facial vein. This time you can see two catheters. It's a different case. I went two catheters through the superior petrosal sinus. That's why I talk about all the anatomy. And here, two catheters in the cavernous sinus, and again, gazillion coils, into it. But sometimes we fail. So here is a case that I put probably like maybe 15 coils in it, but you can still see the shunting still happens, and even more coils still shunting, and we end up sacrificing the carotid. So sometimes even despite best effort, we fail and have to sacrifice the carotid. But again, this patient thankfully has excellent collaterals. That's why we study the collaterals up front, and we know that we have that option if we have to. So this is a case that we went from a different route, the superior petrosal sinus, and we failed ultimately taking a carotid, just like the very first case. A little bit of a different flavor. So this is the first case I'm showing that when you inject the internal carotid, it looks pretty normal. You don't see any problems with it. Now you inject the external carotid, you see the same issues. So this is a type C fistula. It's just from the external carotid. You can see here the superior ophthalmic vein, the same outflow vein, the cavernous sinus. So in direct CC fistula, this case, I just went through the inferior petrosal sinus, which is actually the workhorse. So this is always my first try. So you see this is a pretty nice venogram of the cavernous sinus. You can see it's connected on either side. You can see the inferior petrosal sinus here. I went on the left side, got access to it, and again, just putting coils in it, and in this case, just with coiling alone, again, transvenous coiling through the IPS would cure the fistula. So this is the probably, I would say, maybe 60-70% of the time you can just go transvenous and via petrosal sinus into cavernous sinus and coiling, and that's the job most of the time. A different case, again, this is the case that you injected the internal, you don't see that scary looking angiogram. Kind of already tells you this is an indirect fistula. So let me see if I can show the next one here. Yeah, so now here you see, again, just like the last case, is from the external carotid artery, and it goes right to the cortical veins here. And thankfully, we're able to find an arterial route, and this is the onyx. I want to show a case that we actually use liquid embolic. So this is what it's like when we inject the onyx from the arterial side. So thankfully here we find a small artery that's very close to the fistula. We injected the liquid embolic, and it basically crosses that connection all the way into the cortical vein, and we cure the fistula this way. And this is the final result. Just going to quickly show this. Okay, so we kind of went through the standard treatment. So again, for our trainees, most common treatment is endovascular. So if you ever see an exam, they ask how to do it. It's almost always endovascular, almost always transvenous. I think coiling is a very good first choice. There are some other ways now that we do it. So again, repetition, showing this kind of scary-looking angiogram for the direct fistula. And in this case, looks confusing here. A lot of catheters and wires. So basically in this case, I showed this because we're actually going to the venous side from the artery. So this is a carotid artery. So one catheter, we have it all the way across into the normal arteriotory beyond the middle cerebral artery. The other catheter went through the hole into the cavernous sinus. So of course you can go from the artery to the venous side, there's a hole in it. So here, that's kind of what we did. And rather than using a balloon to protect the carotid like I showed in those two cases, here we use a stent. So here, we use these kind of flow diverting stents. So we used to treat aneurysms to kind of scaffold and protect the carotid while you coil the cavernous sinus. So once you have the stent, it's interesting. I started doing these in the last couple of years. So you can see that once you put the stent in, that shunting of blood is way less. So now you can already see normal perfusion and much less filling of the cavernous sinus. So even after one device already, it looks better, but of course it's almost never curative, and you have to go with the coiling part. This is just part of the coiling, and then after the coiling and the stent, we're able to cure the fistula, and I'll show the final result here. So again, you don't see that scary looking angiogram anymore. You just see normal perfusion of the brain and no shunting of blood. So in my mind, this is, a lot of people are doing it now, so it's not truly that novel, but I do think this is a better way. So you're protecting the carotid artery without arresting flow, unlike the balloon. You see that kind of flow diversion effect to slow the shunting down, so I think you can use less coils. And it's probably also a scaffold for the healing of the artery, as the artery heals. So I think now I kind of get to the last part of the talk. So everything we've talked about so far is what we've always done, right? To treat these fistulas, you always have to have a way to get to the cavernous sinus. That's why we spend time talking about anatomy. We show all those veins, but there are some cases that there's actually no kind of peripheral vascular route to get to it. So what do you do in those cases? And I think these are the cases that I think is very, that's why we're blessed to be neurosurgeons and can do this a different way. So these hybrid approaches, of course, other people have done it, have thought about it. So this is a case from London, Ontario, maybe over a decade ago. So very interesting case. So this is a indirect CC fistula, and you can see the only access to the cavernous sinus is the sphenoparietal sinus, or through the superficial middle cerebral veins. So, and of course, you can't get to this veins really through the groin. There's no percutaneous access to this. So in this case, the group did a craniotomy. So they did an open surgery to find that vein. Then they directly cannulized the vein, just like we cannulized the supraepithelioid vein with a cut down. So the same strategy, except here to do a craniotomy with the neurosurgeons, and then they went with catheters, and then you see here and they coil the cavernous sinus. So once you get the access, the rest of it is the same. But here you need an open craniotomy to get the access and the curative fistulas. So I just want to kind of talk about 3 hybrid approach that I've used in the past, probably several years. These are a few cases to show that we've used, and I think they offer some interesting ways, kind of out of the box ways to think about how to get to the cavernous sinus. So I'll show this first case again. Some repetition. So elderly woman, coming in. So this is probably not a direct fistula, but she presents very interestingly. So not an ocular presentation. This is actually like a stroke presentation. She came in with right-sided weakness. So kind of back to the very first slide. CC fistula can present with hemorrhages. So this is the case. So she came in with this hemorrhage. So thankfully she came with a history. Otherwise, I'm not sure if I would really work her up anymore. She has hypertension, she has this hemorrhage. So she was known to have a CC fistula that was treated 5 years ago. And you can see now when you look at a CTA, there's a lot of fullness around the cavernous sinus. This is the prior onyx, the same liquid that I showed before that has been done previously. So, and this is her angiogram, and I'll just let it play. So very similar case to the one that I showed that was published. So again, you see the cavernous sinus filling early, but there's really no great access to it. You don't see like a huge superior ophthalmic vein. You don't see the inferior petrosal sinus. You don't see really any route to go to it. So and interestingly, for our students, so this is the bleeding, and you can see it's bleeding actually here from a venous aneurysm. So it's a pretty good correlation. You can even actually see it on the CTA originally if you look carefully. So here I try. So I probably spent a few hours from the groin to try to get to that, but there's no inferior petrosal sinus is thrombosed, so I couldn't get through it. There's no superior ophthalmic vein. So here I even try to go from the other side. So I went through the vena Galen, basal vein Rosenthal, but like in these fistula cases, if you don't get there, it just ends up with frustration. You try hours, and I just couldn't make this turn not even to the aneurysm. So if I close the vein here, it's just going to pressurize the venous aneurysm, and it's going to cause a rehemorrhage. So what do we do here? So I literally try hours for all this stuff. And then I look back at the CTA, and you realize that all the pathology is actually right next to the sphenoid. So as neurosurgeons, there's something that we're pretty used to. We do transnoidal for pituitary all the time. So we did this in the hybrid room. So here, it's actually the second time that I did this kind of approach. And the first time I made the mistake of having a super long tubing. So when I put the DMSO in, it melted the whole tubing. So it's plastics everywhere. It took up like 5 cc's of onyx in the tubing. It was a mess. So if you guys want to do it, this is actually, so it's a good setup. So I use a biopsy needle, and I use a very, tubing with very small dead space. I found this tubing that's only like 0.6 cc dead space, and it's pretty sturdy. It doesn't melt with the DMSO, and you don't need a lot of onyx. So this is pretty good. And of course, you need a control angiogram. So we did a radio angiogram. It's a control angiogram. We work with our ENT colleagues, and this is us here, kind of taking off bone from the sphenoid, and drilling the sphenoid right off the dura where we're gonna puncture. So let me see if I can. So here we use stereotaxy to show us. So now we're opening up the bone. Now we're right on the dura where the fistula is. So I'll show this is pretty cool. So there's that biopsy needle. So we're like here, we're just kind of popped into there. So my partner was holding the secondary, we're popping in. We do a venogram. So now we're at the right space. Actually, very straightforward access. We try all the other stuff, and here we directly access it. And so this is the needle. We're injecting contrast to make sure we're in the right space. And from here, we start injecting onyx. And you see here, we start doing that liquid injection, just like we did in the last case. So here is onyx kind of going through. It's really pretty cool. So we injected it. I want to make sure that I get that venous pharynx. So I injected till I see that venous pharynx fills, which I think is right here. And then I stop at that point. And here it's pretty nice. You can actually see the onyx refluxing once you filled it. The onyx refluxing back under the endoscope. for the surgeons. And then we have a, control run, probably injected too much, you can see here. But here, and then this is the final angiogram. Have a pretty nice curative result without any shunting. So we so that's one way, right? So for the surgeons, actually the cavernous sinus, especially when the pathology is anterior to the carotid, this is a pretty good route. I've now done it in a few cases. Actually, this is another actually really interesting case. The same kind of scenario. This is an older gentleman who has the bulging eye, the chemosis, and visual loss. In fact, when I saw him, he already had a canthotomy because he has very high intraocular pressure. So this is a very challenging case. Again, the principle is easy, right? We just want to plug the cavernous sinus, but how to do it is very difficult. So this case here, you can see, I pause it right here. This is the problem here, right? Right here. It's behind, it's the posterior cavernous sinus behind the carotid. That is the point of fistulization. And if you look at this carefully, this is the thrombosed superior ophthalmic vein. That's why I developed acute symptoms. The vein just got thrombosed. And this the sphenoparietal sinus, and I'll show you there's a tight stenosis in there. And there's really no outflow to this. So let me see if I can just fast forward this. So this is a microcatheter run from the accessory meningeo from the external carotid artery. Okay, here. So this is that pocket of the cavernous sinus, and you can see no inferior petrosal sinus, no superior petrosal sinus. And again, I always try, and I just can't get there from the groin. And this stenosis in the sphenoparietal sinus. So even if you do a craniotomy, you wouldn't be able to access this one here. So and then the thrombosed superior ophthalmic vein kind of flowing out. So again, no route from the orbit going to this. So what did we do? So I was actually brushing up some textbooks. I was thinking about doing an approach to the cavernous sinus to maybe to use the stereotaxy to just expose it and inject it, but it'd be a pretty morbid procedure. You have to do a clonidectomy, you got to do a lot of exposure for that. So my functional neurosurgeon, actually it's my resident from Baylor, he said, hey, why don't we try, he says, well, like I do stereo EEG all the time. Why don't we try to use the ROSA robot? So this is a robot we use in epilepsy to place electrodes to localize seizures. So that's kind of what we did. So I said, well, okay, well, I guess never done it, but if you're confident we can do it, we'll try. So here we're registering the ROSA to the frame, and this is what we were planning. So we're planning a transcranial, which is very unusual, right? We usually try never to touch the brain when we do anything extradural, but in this case, there's just no way to access it, probably without doing almost like a Doling or Parkinson type of surgeries to access the cavernous sinus. But here he's like, oh, why don't we just put a small needle, the same biopsy needle through the brain that we do all the time with biopsies and EEG, right to that target of that small pocket. When he first told me, I said, you're crazy, but I'm like, okay, want to try, we can try. So that's the nice thing about neurosurgery and neuroscience, right? We can be innovative, we can try new things. So here, that's what we did. So this is the ROSA robot, so dial in that trajectory. And here we're drilling a very small hole, and we put a bolt. So that bolt is only 0.7 millimeter in diameter, so you can put something very small. In fact, we tested it before. The biopsy needle actually fits through the bolt. So this is what we're doing here. We're putting the same needle this time through the brain to the cavernous sinus. So first time doing it, so that's why I did the O-arm, just to confirm that our needle is in the right trajectory, which it is here. And I thought this is a pretty cool picture to entertain the neurosurgeons here. You can see here, this is the needle. It's right on that pocket of the cavernous sinus. So really, really pretty cool. And I'll play the rest of it. So here is an AP view. We're just about to puncture that pocket. You can see like the needle here. You can see like the pop coming up here. So it's just kind of pop into the pocket. We do a venogram like the last time, do the venogram, and this is still in that pocket of the cavernous sinus and the outflow cortical veins, and I'll see if I can show the next one. So here we inflate the balloon and carotid. So when we inject the cavernous sinus, we'll worry about the liquid kind of flowing back from the venous to the arterial side. So this is my partner actually injecting the onyx lifetime. You see here, he's pushing the onyx on the screen. You can see here is filling up that venous pocket with the onyx, just very much like the last case, So we just want to make sure that we got it, so we filled a little bit into the cortical veins that have already been arterialized. So it's okay to inject this. So I thought it's pretty cool. It's a needle through the brain with onyx syringe out there. And again, I'll show you the results. It's a nice result. So we have an intraoperative angiogram, and the fistula here is cured in this route here. So I'll end with one last case. So not everything we see that looks like a CC fistula is a CC fistula. So there are other even more rare pathology. This is an orbital fistula, and I'll show you the picture. This is an older woman. Again, when you hear older woman, red eye, from neurosurgery, probably an indirect fistula, right? And I'll show this case here. So this is the superior ophthalmic vein, dilated superior ophthalmic vein here. This is the ophthalmic artery, very dilated, way more than what you usually see. So this is the supply of the fistula. You can see there's an orbital hematoma there, pretty big size hemorrhage in the orbit, compressing the optic nerve, and then the inferior ophthalmic vein. And also you can see the fistulas. We're actually medial in the orbit. I think the angiogram would show that much better. So I'll pause this here. Focus on the lateral, the one on the right side. So the ophthalmic artery here, which is enlarged, and this is the supply of the fistula. And then you can see it fistulizes the inferior ophthalmic vein, which is where the arrow is there. So the fistula goes from this ophthalmic artery down to the anterior portion of the inferior ophthalmic vein, and then it backflows out to the orbital apex, and then retrograde back out to the superior ophthalmic vein here, and then the angular vein and the anterior facial vein. So this is an orbital fistula because it doesn't go anywhere in the cavernous sinus or anywhere intracranially. So it presents like a CC fistula, but it's actually an orbital fistula. But the treatment is the same. So here we, just in the sake of time, I'll just show the treatment here. So here we went transvenous. So again, from the femoral vein up to the angular vein here. And this is the mistake that I made. So the catheter is not long enough, the catheter is a little bit too short. So I couldn't really get to the front part of the anterior ophthalmic vein. So I coiled it a little bit short of it. And this is the problem. So you did the coiling, and now the fistula still fills, and you lost the access. You can see here that the fistula here still fills. You lost the access, and the patient symptoms are no better. In fact, it may be even a little bit worse at the time. So what do we do? So I ended up taking the patient to surgery, and again doing a direct puncture. Here is for the non-surgeons, this is the stealth system, the stereotaxy. So we use a hybrid room. Again, working with oculoplastic surgeons, make a subciliary incision, basically right above the floor of the orbit, and we just mobilize, we push away the globe a little bit, and then we just use stealth, just like we do a biopsy, and we just kind of directly puncture the rest of that vein there. This is us kind of getting into that. Every time you're in the fistula, you should have arterialized blood. So if you don't have arterialized blood back, you're not in the right spot. So always want to make sure that you can see that bright red stuff in the syringe. That's arterialized blood, so you're in the right pocket of that. But also confirm it, with a venogram, like we always do. So here you inject it, you're at the right place. You can see that's the place that we missed with the coiling. So again, to the fellow, when you do the coiling, you want to make sure that you coil the part that is the fistula. So here you see the here, and then again the onyx injection, into it. Again here, filling even this tiny branches that comes from the ophthalmic. Of course, be very careful that you don't get to the ophthalmic here. So we stop as soon as I see these small branches. I just stop, and here you can see before we did it, the vein here still fills. And now afterwards, there's no more shunting. The ophthalmic is intact all the way down. So also the other advantage of doing it in the OR, this patient also has a big orbital hematoma an uncommon situation. So here, the oculoplastics people even did an endoscopic endonasal decompression. So they just decompress the medial wall of the orbit just to relieve that pressure. So that's another reason why we did in the OR. You can have a kind of hybrid approach and decompress the orbit. So in summary, again, for our trainees, even though in the past we did all kinds of stuff, neck compression, surgery, but really endovascular therapy is the way to go now. So if you guys see a CC fistula, please, call Mandy and Errol's group. They're the group who will take care of this pathology for you, And coils are the most common, but other things, like we show flow diverter, liquid embolics, are all in the toolbox. The funny thing is that really, if you don't have visual loss and you don't have a risk of hemorrhage, these things are not truly emergent. You could have a red eye for a couple of months. I mean, it's not, you don't have to really send to the ER and that, unless if they're acute visual decline or if they're intracerebral hemorrhage or the risk of that. But I think once those things happen, then you're talking about like an urgent treatment. And in fistulas with no direct vascular access, this kind of hybrid approaches that I show can offer a minimum invasive curative treatment. So thank you very much, and happy to answer any questions. Thank you.
Thanks, Peter. That was a really awesome talk with really great cases, and I didn't know you could innovate with CC fistulas, but that's really great. I have one question. What is your follow-up for these patients, especially the indirect patients?
Great question. I think I think if the treatment is successful, the symptoms should always go away. So I think if the patient is heading in the right direction, usually it's pretty quick. Sometimes even overnight, you can start seeing some improvements in the directs. Even in direct, in a week or so, their eyes usually 80% better. So I follow them clinically. I want to make sure that the symptoms are getting better. If not, I'll do a pretty early angiogram to see if there's something I miss. If they're getting better, I don't do an angiogram until 3 to 6 months afterwards, but I always do one. And in fact, if you look at the literature, even a lot of kind of incomplete treated fistulas can go on thrombose. So I think if you do a follow-up, so I found clinically one angiogram at 3 to 6 months, and if the fistula still fills a little bit and the patient is not having kind of retrograde filling of cortical veins, or symptoms are not bad, you can even wait. It can thrombose, But that's kind of what I do. I do think doing one angiogram is important for these cases, even if the patients have no symptoms at that point. So,
Peter, thanks. That was a great talk. I think this is something that everybody sees at some point in their practices and maybe misses, but not a lot of people know the details of it. And so that was a great overview. So my question is, with everything going the route of endovascular, back in the day, as you know, all we had was open, right? We treated these with open. Can you remember we would expose a cavernous sinus and literally with an 11 blade, nick it and stuff it with gel foam, and Surgicel worked the best. And actually it worked quite well. And we went from that, I think, to a point now where we're actually using robotics for a pretty simple pathology, right? It's a fistula. It's an artery and a vein that are combined. So my question is, the balloons that you were talking about, the gold valve balloons, in the history section, those were great balloons. You inflated them, you detached them, you left them, and it was a plug. Then we went to coils. You mentioned one of your cases, it was like 50 coils, there was a recurrence. For those of you that don't know, each coil is between $1,000 to $2,500. So you multiply that times 50, and then the patient's still coming back. Where do you see flow diverters? Because I think, to me, flow diversion, given the caveat that you have the access, seems like the best option for these.
Errol, I'll pull up that case one more time here. Is that case with the flow diverter? Let me see if I can quickly find it. So, yeah, this is the picture, Errol, that we let's see. Right, so this is what it looks like after one flow diverter, right? so it originally generates a lot of interest in me. I'm like, well, maybe we can stack a couple, but I think the problem is that for the direct fistulas, I don't think you can ever cure it. I think what this does is that it allows you to put less coils probably because it just slows down the flow, allows you to put less coils, allow you to protect the carotid better. And I think also heals nicer because now you have a scaffold for the healing. So now for me, for a direct fistula, I always do this. I always put one flow diverter on the arterial side so it protects the carotid. It allows it to heal with a scaffold. I maybe will use less coil. Then I go to the venous side of coil. I think with that much demand, you really cannot shut this down with unless you have a cover stand, I think. Otherwise, I think with the flow diverter, it's hard to shut it down.
Yeah, and let me clarify, the caveat is that you are putting something in there to slow the flow down. A couple large coils.
Yeah, so I think, and then the other question is that, I think a more interesting question to Arrow is that, so for the indirect fistulas, the ones that I show with no routes to it, can you put a flow diverter there and would it, those are never done because I think when there's demand through the fistula, it won't close and then your patient aspirin Plavix, you have the stent in, the fistula still fills, and then the other options become even more limited, surgical options, so I think I don't think flow diverter would progress beyond maybe this type of role in the treatment of this pathology, but obviously it has done wonders in aneurysms and like other things. So. Yes.
Oh, Peter, I'm sorry, then I'll
Yeah.
hand it. Again, that was a wonderful talk. Thank you so much. Just the anatomy and just going over the history, I really enjoyed it. We've talked about, and obviously as a neurosurgeon, we're talking about treatments and endovascular or invasive treatments. For type C and or type B and type C, there's low flow fistulas. Do you ever try, depending on the symptoms, just cross compression?
Yeah, that's well described, and I think to Dr. Lehman's point is that I think sometimes in neurosurgery, right, we jump fast to treat people, but the truth is that if someone has no raised intraocular pressure, no visual loss, no corticovenous reflux on the angiogram, that patient, you can try other things, right? There's no harm to try. Okay, fine. Let's see that at some point. So that patient, I think, is perfectly fine. And what Ken is talking about is kind of this carotid compression, just like the Tower technique, basically. And it works, I think, 10-15% of the time, right? I have to say I've never prescribed that, but but it's in those cases, there's no harm to try, to compress the ipsilateral carotid with the contralateral hand, right? So even if you get ischemics, supposedly your hand would just drop off, I guess, but usually it's fine. I think that's a great point. One that carotid compression can work like 10% of the time, and also not all of these things needs aggressive treatment. Some of them you can wait.
Thank you. It's great talk. What about your minimal direct puncture? How you fix the sheet? Like when you do robotic or you just puncture with needle, how you fix the sheet or treat
For the case of superophthalmic vein, I just used the microdilator, so that you can put your microcatheter through it. So I just put the microdilator, I just put a tie that to the vein so it doesn't come out. And then I just put the TUI on the microdilator directly, and then the microcatheter through that, So the problem with all these cases, as you know, the catheter is designed to go femoral, so you always have a ton of catheter left out. So some people would even put like a 4-French catheter. Like most of these veins are big enough, you can actually put a 4-French catheter. That's what I do when you do the combined approach to sometimes you open up the transverse sigmoid sinus and direct puncture. I think those I'll even leave a diagnostic catheter so that it gives you something so you don't have a 150 centimeter microcatheter dangling and you try to do that, right? So I'll use the diagnostic catheter, but it's not always possible, not always necessary. I find for the CC fistulas that the system is usually okay enough. You can just let the catheter stay in the body and it's pretty stable. I think the harder ones to do are the ones in the back. Like those are really unstable. Those I tend to put a diagnostic catheter through the sheath just so that you have something to protect that microcatheter. So.
And what about your experience from onyx injection? You have a lot of, I don't know about cranial nerve injury or
Yeah, so in,
Sir.
so a good question. So in the literature, as you know, the risk of injuring the cranial nerve appears to be higher with onyx, with liquid embolic. So I think with the coils, the idea is that it goes between the nerves and the vessels. It doesn't destroy them. It just kind of goes in between and pack the space. With the liquid, it's harder. It may damage the blood supply to the nerve with the liquid. So people say that the risk of the cranial nerves is higher if you use liquid. So I still prefer to use coils whenever I can. But these cases that I show, when you do the direct injection, there's just no way you can do coils, so those cases I use liquid. But in general, I would prefer to use coils. And I think I don't have a series of 100 of these cases. So but look at the literature, the onyx or the liquid, supposed to give you higher, cranial neuropathy. I mean, Errol and Ken who have more experience actually like in doing this than me. I don't know, you guys notice that at all? You guys use coils or liquid? Or?
They're both compressive. I mean, that's the idea. Disclosures where that came up is some type of adjunct because, I mean, you shove any mass in there with the cranial nerves, as you know, they're exquisitely sensitive. So, I mean, I don't know the answer. I've seen problems with
Both, yeah.
I share your statements that with coils, you would expect, I don't
Yeah.
experience a lot of cranial nerve issues.
Correct. Which is pretty surprising when you pack you pack 50 coils in the cavernous sinus. You think everything is like compressed, but it's pretty surprising. Most of these people come out and they're pretty happy patients typically, because usually it's pretty miserable. Their eyes are super swollen. They can't close their eyes. The vision is going down. They're pretty grateful. Yes.
I'm one of the PAs for the practice, and we don't see too much into our stuff. But when we see these patients in our outpatient, what is a real expectation of vision returning, pain getting better?
I think
And
that's
is it more on how long they've had these issues that?
Yes, but I actually think that the symptoms get better actually surprisingly well, even people with pretty long-standing problems. In fact, a lot of patients we see, they have gone around a little bit, because CC fistula is pretty rare. They often think they're glaucoma, they have like an eye infection, and they bounce around a little bit, so people usually come and see you and your group when they've usually see an ophthalmologist for a couple months, try eye drops, steroids, and all that. And surprisingly, their symptoms do improve quite significantly. Even I have patients, both direct and indirect fistulas. There are people who has come 2 years after their onset symptoms and treat them, and their symptoms do go away. And I think usually, I think the vision return takes the longest. All the chemosis, the exophthalmos, those are very quick. Usually within a week, you see a difference. But the visual decline, it comes back slower, but it do come back.
Well, Peter, that was very, for our first in-person talk, that was a humdinger, so thank you.
Oh, thanks everyone. Thank you.